So without further ado, we're going to turn over to our alumnus, Dr. Boutros, up at McGill, to hear from her about some innovative strategies for managing colorectal surgical complications. And Marilies has kindly left lots of time for good discussion, so don't go far from your microphones because we want to have a lively, interactive meeting this morning. Marilies.
Thank you. Good morning, and thanks very much for this kind invitation and for having me on the conference. I'd like to also thank Pat Silla and Giovanni Milito, who provided me with cases and videos and helped me get other videos and cases from experts around the world. So in the 1800s, William Halsted, rightly so, said that the colorectal anastomosis is a difficult anastomosis, and even in the best of hands has pretty dismal results. Fortunately, we've come a long way since then, identifying key technical factors for a good anastomosis, and with research and experience, other patient and disease factors that are really important to consider when making an anastomosis. However, as Halsted said, even in the best of hands and despite our meticulous efforts, a perfect anastomosis or a perfect result of an anastomosis is not always attainable. And unfortunately, complications such as bleeding, leak, which we all hate, and a chronic fistula from the anastomosis, and resulting stricture at the anastomosis are all too common complications that we experience in our practice. The standard approach, before we talk about the innovative approaches, it often involves wide drainage, diversion, revision of the anastomosis, reoperation, all with very significant morbidity to the patient, with lengthy hospitalizations, and in some cases, a permanent stoma. Because of this morbidity and cost to the patient and our system, several innovators have come up with ideas to minimally invasively approach anastomotic leaks and anastomotic complications. Of course, the perfect patient has to be at hand. A patient that is in peritonitis or is unstable is not a patient in which to try innovative, minimally invasive efforts. However, if the patient is stable and there's room to try an innovative, minimally invasive approach, multiple technologies have been developed and people have tampered with them. We're going to address these through several cases. So the first case, a 60-year-old woman undergoes a lap anterior resection for an early colon cancer, uneventful operation, and on post-op day 4, after she had already started passing gas and tolerating food, she has a fever, lower abdominal pain, and she stops passing gas and vomits. Her abdominal exam is soft, and she's hemodynamically normal. A CT scan is obtained, and you see it here. As you see, the abdominal cavity is without free air or free fluid. However, in the pelvis, there is a presacral abscess just behind the anastomosis. It's percutaneously drained, and she's kept NPO on TPN, and she clearly states she wants to avoid an ileostomy at all costs. A repeat CT scan, as you can see here, demonstrates a collapsed cavity with the drain in place. However, the drain is still draining. Gastrograph and enema a few weeks later demonstrates the cavity has still not collapsed completely. So what are the options here?
Okay, so thanks. That's a good point at which to ask a few folks their opinion. Let's turn first to main campus and see if Connor wants to volunteer someone at main campus, Cleveland Clinic, Ohio, to talk about how they might approach this situation at this point in time.
Steve, I'd be happy to, but I'm here with Emery Gorgon, and Emery, as you know, has done a huge amount of advanced endoscopy and is very innovative, and I thought it might be great to hear his perspective.
Okay, Emery, thanks. Let's hear how you might manage this patient who wants to desperately avoid a stoma at all costs.
Yeah, I think we need to first evaluate the patient for sure. I would start out with an exam under anesthesia. That would certainly include a flexible endoscopy as well, and to put a scope through the anal area and take a look at the entire anatomy, and see if we can even get into see how big the defect is, and see if we can even get with the scope into the abscess cavity too, and then take it from there. Obviously, first evaluate and assess, and then go from there.
So let's say you could get the scope into the abscess cavity. What would you do at that point?
Well, depending on the height and size of the cavity, there are certain things. In our department here, I didn't have much experience with that, but endosponge, this was mentioned at the beginning of this talk. I think that's one of the options. Other things, usually I prefer or like to clean the base of the abscess for sure, potentially debride the whole cavity and go from there. But for resilient, resistant cavities also we have done here with Victor Fazio in the past is to unroof the abscess cavity or presacral space and incorporate that into the anastomotic space. I have had good success in a couple of patients with this approach, where I use an endo GIA, even laparoscopic GIA stapling technique.
Steve, just to add to that, I think they're great comments by Emery, but I think the sponge, although it's challenging to get in the US, tends to be better for very early things. We're getting a huge amount of transfers at the moment for management of these delayed presentation or tried something, doesn't work options. And one of the other things we're doing increasingly is with the advanced endoscopy team, Bo Shen is doing a lot of endoscopic sinusotomy. And the success rates with that, so much like Emery's describing with an endo-GIA or with cautery, but the success rates with that are very good, and he has a paper coming out on that soon. Obviously, people also talk about using clips and other things, but I'm sure we'll talk about it later on, but the evidence to support all of these things is questionable. I think it's a great area to look at.
Good. That gives Marilee some, the gauntlet is thrown down. Let's try Florida Hospital, just up the road in Orlando, and see if John Monson, okay. So, Steve, you're going to tackle the anterior section leak or pass the ball to someone else? Curious how you guys would handle it.
Good morning, Steve. As you know, with Rob Hawes and his advanced endoscopy team, they're certainly part of our solution. We involve them, but many of the things that they have on hand to approach these with really rely upon a fairly small opening and adequate tissue on the edges. Otherwise, a clip's not going to be effective if you're simply clipping necrotic tissue or if you're trying to use an overstitch. Scott Bloom is here with me this morning, and he has far more complications than I do, so I'll ask his opinion on this. Also, Scott actually does a lot of our robotic colon surgery, and so I'd appreciate his opinion.
Well, thanks, Dr. Eubanks. Yes, I've tried to build a career on complications. One option that we didn't discuss is perhaps approaching it for wider drainage laparoscopically. I think that the drain had been placed percutaneously by IR in the case it was presented, and if that's not giving adequate drainage, then perhaps going in laparoscopically to place a drain in the pelvis for additional drainage is probably where I would start, given that that patient is very reticent to discuss defunctioning stoma.
Okay, so a couple of different ways to slice this. Marilee, why don't we go back to McGill University? Let's hear how it was managed up north of the border.
All right, well, thanks for the comments and ideas. And as the speaker stressed, the size of the opening and the quality of the tissue is, I think, the key factor. And in this case, it was just over a centimeter pinpoint hole. However, it's been about 6 weeks now since this has occurred, so the quality of the tissue was a bit stiff. What we tried was through the clip, normal hemoclip, through the scope, and as was mentioned, first of all, the hemoclip is limited to the size of the working channel of the scope, so it's not large enough, didn't have enough force, and the edges just wouldn't come together. The hemoclips are really best and made for colonoscopic perforations, and even at that, they're not excellent. As you see, in order to close a colonoscopic perforation, usually need multiple clips. Just a quick look at the data for hemoclips for colonoscopic perforations, about a 75% success rate at getting the defect closed with, as you see here, a large number of clips. However, abscess formation and avoiding surgery are still not complete at least 25% of patients requiring surgery. How about using hemoclips for colorectal anastomosis? Really doesn't work that well for the reasons that we mentioned. A couple case reports in the literature, that's about it, that have had some success using it. Again, as you see with a numerous number of hemoclips, some patients requiring diversion. So this patient was then approached with an over-the-scope clip, and here's a video kindly provided by Dr. Arezzo. Here you see a surgical drain, and here you see a defect, very similar to the defect in our patient. And the over-the-scope clip is mounted on the endoscope, and as you see here, they're using a suction technique. And what's very important with the over-the-scope clip is you really have to center the defect in the middle of the clip, because after that it becomes a bit blind, as you're seeing or not seeing right here. With the suction on, the clip is fired in place, and it's kind of like a bear claw that holds the defect closed. And here's the final result. You see the lumen and you see the defect being closed. So the over-the-scope clip, there's several companies that provide it, but the general technique can be one of two ways, either by suction, as was in the video, or using a grasper through the working channel, and it's a grasper with two claws, one to hold one edge of the tissue, and once that's grasped, the other claw grabs the other side of the tissue to try to approximate them, pull them into the endoscope, and then the clip is fired. So back to our patient here, the over-the-scope clip was placed, closed the defect, and the drain stopped draining. After a few days, the cavity remained collapsed, the patient was fed and sent home. So over-the-scope clips are not a panacea. However, early results by Dr. Arezzo from Italy demonstrated that reasonable success. Some of the patients that he used it in had larger cavities that were brought to a small size using the endosponge, and when they had a defect size with a median size of less than a centimeter, the over-the-scope clip was applied with an 83% success rate. As with most technologies in surgery, with time and experience, the success rates dropped. So you see several other series here with about a 50% success rate. And from the Cleveland Clinic, Dr. Wexner's group published a series of 21 patients, and for lower GI anastomotic defects, the overall success rate was 33%. Again, pointing to the fact that we had discussed that for leaks, the over-the-scope clip works better than for fistulas where the tissue is fibrotic, and it's very hard, even for this somewhat bigger clip, to bring the tissue closed. So in summary, for endoscopic clips, it allows for mucosal closure and stops the source of bacterial contamination. Hemoclips are really not made for managing anastomotic defects. Their low closure force and their limit in size makes them not ideal. The over-the-scope clips, it's a bit of a blind application and can't remove it once you've fired it. A small series with heterogeneous patients, however, some promising results that for a small defect with fresher edges, it can be closed. Should we proceed to the next case? This is a bit of a larger leak. A 72-year-old woman who underwent an Altmaier procedure at a small hospital presented to a tertiary care center on post-op day 7 with bad anal pain and lower abdominal pain and fever. However, her abdominal exam was soft and she was hemodynamically normal. A CT scan demonstrates a large pelvic abscess with several air pockets.
Thank you. So let's have a bit of discussion on this one, and maybe we can pick on a few other folks. Mount Sinai Hospital. Okay, good. Oh, absolutely. Dan, Pat, okay, here we can pick on a few good people. So, Pat, some of these cases you may know, so you've got to recluse yourself. But, no, let us know how you might approach this one, if you would.
I think,
either way.
I mean, no question, we checked if the patient is stable, I would rather drain this percutaneously or transanally. Probably would actually try to, if you could probably access it transanally and try to drain it, which also would give you a chance to assess the anastomosis. So we actually had a similar case when Professor Alberti was visiting, as a visiting professor. And interestingly, our patient who leaked, he wasn't mine, he was a colleague of mine, actually had C. diff. And he was arguing that the fact that she had C. diff colitis may have contributed to her anastomotic leak, Marlies. I was wondering about your thoughts on that.
Mm-hmm. That's a very interesting point, and I think there's, Yeah, there's certainly, we know when we look at anastomotic leaks, all the work that John Alverdi is doing up at Chicago with different types of bacteria that really eat collagen and prevent anastomotic healing. And I'm not sure C. diff has been studied as one of them in his lab, but it's certainly a very valid point that could well contribute. And it's interesting because back long time ago when I was a resident, I remember one of the staff used to say he worried the most about the patients who had really quick return of bowel function with diarrhea because they were the most apt to leak. So maybe in those days we weren't looking at C. diff, but it's certainly a good idea. So let's see what Marilise did in Montreal, whether she used the Imperial College approach of laparoscopic drainage or other. Let's go back to McGill University, please, and see how she managed it.
So just a quick comment, Pat, about the C. diff and the leaks. We had a bad epidemic of C. diff here in the early 2000s, and I think we saw 3 leaks in the period of about 10 years, and they were in C. diff patients who got C. diff immediately post-operatively. And I think a lot of the bowel edema probably prohibits healing, so we think that it contributes, maybe not at a microbiology level. So here in Montreal, here in Montreal, we would have percutaneously drained this probably and had a look, as Pat mentioned, endoscopically at the anastomosis. However, the video I'm going to show you is going to come from the other side of the world where they are advantaged to having access to the endosponge. So what they did for this case is endoscopically assess the patient after percutaneous drainage. And as you see here, you'll see the percutaneous drain. Here's the lumen, and unfortunately this anastomosis dehisced in more than one area. This is the largest dehiscence, a huge cavity of about 10 centimeters. It easily enters the colonoscope. This was irrigated and with saline and providine. And then the anastomosis also dehisced in 2 other areas, one here causing a rectovaginal fistula. And this is the rectal side, and they will just show the colposcopy next and show the vaginal side. Here you see the fistula opening on the vaginal side. And there's another small defect at the other end of the anastomosis. So they didn't initially divert this patient, percutaneously drained her, and started working with the endosponge. Here the endosponge is seen placed in the large cavity. And here you see the granulation tissue as time passes. The endosponge is exchanged every 3 days in endoscopy under sedation at first for patient tolerance and then without sedation. This patient was kept in hospital. However, after a few days they saw that there was lack of improvement, so they diverted the patient and continued with the endosponge. And here you see progress with the cavity becoming smaller in size and more shallow, and the granulation tissue there. Again, it's irrigated and the sponge is exchanged every 3 days. And I will not keep this going for 21 days. However, as they approach the end of the 3-week period, the anastomosis actually fully heals. So this is with diversion and the endosponge. And you'll see a granulation tissue at the anastomotic line. And what really struck me with this is that with these huge anastomotic leaks, sometimes for months, when they're just diverted and drained, they don't heal. So the endosponge in this case really expedited healing and made healing successful, which I think for a lot of the large leaks, there's a risk that the anastomosis doesn't heal at all. So just a note about how the endosponge works. Under endoscopy, the colonoscope is placed through the anus and the cavity is explored. Once the cavity is explored and irrigated, the colonoscope is withdrawn and a sleeve is placed over the colonoscope, which is then reintroduced into the cavity. The scope is withdrawn while the sleeve is left into the cavity, and an endosponge, which is made for rectal cavities, is lubricated and placed through the sleeve, and then the sleeve is withdrawn. The endosponge is then connected to a continuous vacuum and left there for about 3 to 4 days. When it's withdrawn, a liquid like saline or lidocaine is placed in the tubing so that to break the suction and let go of the tissue so that the sponge can be removed. Some data from Europe on the endosponge. As you see here, again, small series. However, much larger defects are being addressed by the endosponge, of course, compared to the clips. And the number of sponges used are many, over several weeks to months. Sometimes for large cavities, people have tried using more than one sponge. A lot of the authors mentioned in their discussion that even though all patients weren't diverted, they have found much better success with diverted patients and, as was mentioned in the previous discussion, early intervention. Again, when the wound edges are supple and fibrosis hasn't set in. So the endosponge is really most suitable for lower colorectal leaks, as for higher ones it's hard to reach the endosponge. Better success if the patient's diverted. It is labor intensive, uncomfortable for the patient, and expensive. However, I believe that it probably gets some anastomotic dehiscences to close that may not have closed with diversion and drainage and waiting a long time. And it definitely facilitates early closure when successful and allowing the patient to return to adjuvant treatment, stoma closure, and importantly, probably allows for better function in the long term because of less chronic sepsis and fibrosis of the abscess cavity.
And since it's not available in the U.S., I'm just curious at Sharet Zedek in Israel, if Patakia Reisman or his colleagues, if we could turn Cora's call over to Sharet Zedek in Israel and ask if they have any experience with it. Here in the U.S., as you mentioned, it's not available, and so what we end up doing is having to improvise and jerry-rig something using the black foam and an NG tube and suturing the foam to an NG tube, and it's a bit cumbersome, but you can do it. Jim Fleshman in Dallas probably has the largest series, but Patakia, do you guys employ endosponge as available in Israel?
Well, it's not available as the product that was shown, but we do use it, mainly, of course, for wound infection of the abdominal wall. But we also had a few cases that we also just took a large tube or a chest drain and just wrapped a black sponge around it. I think if the defect is very low, you really don't need a colonoscope. You can do it just by an EUA and with the rigid and then you can see exactly what you do. I did have a couple of cases that I just wanted to optimize the drainage, and I added a pre-sacral incision outside of the sort of making a double drainage of the abscess cavity. I thought this may expedite the healing process and better drainage. So this is our experience. I think also that it really depends on the background of the patient. I think a patient after an Altmaier procedure probably has much better chances of healing because he didn't have pre-op radiation, etc., as opposed to a patient with a middle cancer. And I think that has to be taken into your calculation when you're deciding which approach to practice.
Thanks. That's helpful information. So you're also doing the Jim Fleshman technique of homemade vac sponges, and it does work. Okay. Well, let's turn back to McGill University and hear about our next case.
All right. So just changing themes a little bit. A 50-year-old man with an early sigmoid cancer and 20 other polyps undergoes a total abdominal colectomy with an ileorectal anastomosis. At a week post-op, he has fever, some nausea, nonspecific symptoms, undergoes a CT scan, and all that we find are a micro leak with free bubbles around the anastomosis and some fat stranding. We keep him on bowel rest with IV antibiotics, and his symptoms resolve and his CT scan improves, and he's discharged home. He's followed for his cancer follow-up. However, at 8 months, he presents to the emergency room with nausea, vomiting, abdominal distension, really appearing like a small bowel obstruction. And here's the CT scan of his admission. So you see the dilated small bowel loops, but you see a stricture at the anastomosis with dilated small bowel loops proximally and a normal rectum with no mass there. So his CA was normal. And endoscopically, as you see a stricture with granulation tissue. It's biopsied and it confirms granulation tissue. So how would you manage this patient?
Okay, so let's see who we haven't picked on today. How about Stony Brook University? Can we go to Stony Brook and get an opinion on this one? Thus far, we've heard about a couple of other approaches.
Hey, Sam Sabai here. I do laparoscopy, but we don't have any colorectal people, but I was in private practice for a few years up in rural Maine. I had a couple of cases of these, but endoscopically I would have to go back and dilate these serially and follow them clinically if they need another dilation. But that was my experience.
So serial dilatation, okay. That's one approach. Cleveland Clinic main campus in Ohio. See, Emre, how would you do this one?
Connor just stepped out. Yeah, I agree with endoscopic dilatation. That's one option. For the ones that I can reach, though, still I think it's mechanically much more effective. So long dilators we have. I mean, they're as long as maybe 50 centimeters. You know, you would be surprised how far up you can reach with these mechanical dilators as well. For like colorectal or ileorectal anastomotic strictures, I occasionally use these dilators as well. The challenge with those is it's hard to aim into that tiny spot though. I use the endoscopy, still flexible endoscopic assistance, and push it even up to like 20 centimeters, 25 centimeters. You can get a rigid dilator or like like silicone dilators up to that spot. But for the ones that you can't get in, I use endoscopic balloon dilators, and I have had good success with those and avoided redo operations. So I think as a first-line treatment, endoscopic dilatation is really a good option.
Okay, so we've got a bit of consensus there. Marlies, let's go back to McGill University, please, in Canada, and Dr. Boutros, tell us how you did manage it.
So we did manage it with balloon dilatation. I didn't know that dilators up to 50 centimeters existed, so that's the rigid ones. That's interesting, Emery. And definitely I find them more effective. However, this was balloon dilated, first to 20 millimeters, and then first using a 12 millimeter balloon, and then up to a 20 millimeter balloon. And then it easily allowed the colonoscope. However, the patient did require coming back for 3 sessions within the first year, and now he's been followed for 3 years and has been asymptomatic, just undergoing his routine screening. Not much literature actually on balloon dilatation for colorectal anastomoses. However, this recent retrospective review with prospective phone follow-up was published in Surgical Endoscopy. Over 2,000 colectomies, 3% of them having an anastomotic stricture, which they defined as either symptomatic or for the diverted ones with a lumen less than 1.2 centimeters. The median time to developing a stricture was about 5 months. And a median of 3 balloon dilatations were required. So, like was mentioned, that they have to be surveyed and brought back, as it's not a permanent solution for most of them until you've dilated them several times. About 15% suffered complications, including bleeding and perforation. However, these were all managed conservatively. Looking at the recurrence rates, within the first year, about 11% recurrence rate, and at 5 years, about 25% recurrence rate. And the predictors for recurrence in this study were 3 or more dilatations and a hand-sewn anastomosis. Only 2 patients from their series required surgical revision. So overall, balloon dilatation should be the procedure of choice for a short, benign colorectal anastomotic stricture, and it could be done either with balloons or with rigid dilators, as was done in their study. The low colorectal anastomoses were done with rigid dilators. Low morbidity to dilatation and reasonable long-term efficacy. So we'll move on to a stricture that's a little more challenging. This is a case kindly provided by Pat, a 40-year-old woman who with Crohn's colitis who underwent a colectomy and ileorectal anastomosis. That was complicated by a leak for which she was washed out. A diverting loop ileostomy was created. However, she developed an intracutaneous fistula from the anastomosis, and the anastomosis strictured down. For the intracutaneous fistula, Fibrin Glue was tried. Now, if you look at the literature for Fibrin Glue, it's kind of like the literature for Fibrin Glue for anal fistulas. Initially, really good success rates, and then with time, less and less success rates. And for those of us who have tried it, we have found that usually it doesn't work that well. If you're going to try it for a small defect. and you may want to use it as an adjunct to other tools.
Good, good. Very challenging case. We all see it. It's one that we all wish we didn't have to deal with, but we do. Let's go to NYU Winthrop Hospital and see how the folks there at NYU Winthrop would deal with this situation.
I think the first thing is to get control of the situation, understand, is it a high output or low output type fistula? If it's possible to understand the anatomy, once you have control of that with some type of imaging, I think that would be the thing to do as well. And it sounds like there's a stricture here, so clearly with that obstruction, that fistula is not going to close, and if it's amenable to, if it's accessible, then you can try dilatation. In my experience with these types of things, especially with the Crohn's patients, it just doesn't work. And ultimately, I think it'll come to surgery.
Okay, appreciate those comments. Marlies, in the interest of time, let's go back to McGill and hear how you managed it and what kind of incredibly creative solution was employed.
I won't take credit for the innovation here. I think in our hands, this patient would have ended up in surgery as well. However, the way that this case was managed is endoscopically. First of all, it was a low output fistula, and there was no abdominal sepsis. This is endoscopic view of the stricture. And then it was elected to stent the stricture with a fully covered stent in aim to block the fistula opening. And here you see the fluoro that is shot during the placement of the stent. You see the origin of the fistula right at the strictured anastomosis and the proximal small bowel. The guide wire is placed through the stricture and a balloon dilatation is performed. And then the fully covered stent is passed over the guide wire and opened within the stricture. And here you see the fully covered stent deployed within the stricture. There are no fully covered stent for colons, so the team here chose a fully covered esophageal stent, and for an ileorectal anastomosis, this seemed to be sufficient. It kept the lumen open, and the patient did well. At 3 months, the stent was removed, and here are the fluoro images before the stent being here's the stent, a fluoro image being shot after the stent is removed, and you see that the fistula has closed and the stricture has been dealt with. So I think extreme innovation saved the patient a big redo operation. Problem with these stents
Kudos to Pat Silla, that's
Yeah.
her case, by the way. Great job, Pat, and I think we can all learn a lot from the way you handled it.
Exactly. So stents, there's self-expanding metal stents, there's biodegradable stents, there's stents that are fully covered, partially covered, and uncovered. The idea for the fully covered stents is that it blocks any communication, of course, between the lumen and the extraluminal space, and allows for tissue ingrowth. The problem is that they're really meant to be placed within a tumor or within abnormal tissue, and so when they're within normal tissue, they easily migrate out. A recent systematic review looking at these stents for anastomotic complications, 31 studies, but every study included 1 to 40 patients, so small series, including overall 200 patients. The indications for the covered stents were leaks, fistulas, strictures, or a stricture associated with a leak in fistula, such as in our case. And the early success rate, meaning being able to just deploy the stent, in about 3/4, early complications such as bleeding and perforation in about 1/3, complications requiring surgery, about 10% of patients, but in half of patients the stents migrated, they just couldn't hold in place. For the anastomotic fistulas and dehiscences, closure of the dehiscence at first in 75%, and overall in the whole group, long-lasting success in about 50% of patients. So in summary, for the stents, still small retrospective series. At best, it may benefit half of the patients. There is a significant complication rate that we have to keep in mind, but so is there with a radical operation to fix the problem, such as in the case that we just had. Okay, so moving on to more fistulas. A 69-year-old male with an advanced rectal cancer, mid-rectal cancer, underwent neoadjuvant chemoradiation. He underwent a laparoscopic proctectomy with a stapled low colorectal anastomosis and a diverting loop ileostomy. He did well postoperatively, went home, And on post-op day 10, he represents to hospital because of foul-smelling mucus, he calls it, leaking per anus and a sore anus. A CT scan of the abdomen and pelvis are obtained. He has no free air, no abdominal abscesses. However, he does have a presacral abscess. In our institution, these are usually percutaneously drained. He's sent home with the perc drain, and he's on diet and antibiotics. However, it's still draining at 4 weeks, though the drainage is small. What are your options at this point?
Okay, let's go to Florida Hospital again and ask John Monson how he might manage this case now, 4 weeks after drainage. John, welcome.
Thanks, Steve. I think the key is, he's covered, diverted. So if this is just a modest anastomotic leak, a short period of drainage should be sufficient. So I would, at 4 weeks, I'm beginning to get slightly concerned because I don't like leaving those drains in too long, because I've seen a few cases where if you leave them in, you end up with a fistula, percutaneous fistula, and that's a really big problem. That's going to be a problem to fix. So I would, be looking to have that drain out in 7 to 10 days max. And if it is not controlled by that, I think you're probably beginning to get signs that this is a bigger problem. I don't get a sense as to what the anastomosis looks like. From Marlise's description, is this a small leak or is it basically hanging in the breeze? Because I think that's really the key issue. Is this anastomosis salvageable or is it gone?
Yeah, good point and worth knowing. So generally 7 to 10 days. Here we are at 4 weeks. How about Anna Rundle? Adrian Park, I don't know who you have up there from colorectal or general surgery wants to tackle this one.
Yeah, hi Steve. We're a very interesting discussion. We don't have any of our colorectal surgeons right now, and just as I'm listening to these presentations, I'm thinking we have a far less adventurous advanced endoscopy group here than we probably should have. So I don't think I have a whole lot more to offer. I do have a question though from one of the early, I think it was Connor. The idea of the endo-GIA, we've actually done that once before in a situation more for Stricture than for this. But the question is the sinusotomy or the use of the endo-GIA. What kind of rectal emptying do you get after that long term? How does that impact emptying? So sorry to do
Personal experience with those things is it's one of the things that's probably been published more often than done. And although there's a handful of people, including myself, who will occasionally do it, it's not widely practiced. And part of it is, the poor function, but the other part is this is a leak against the sacrum, and patients have been known also to come in with osteomyelitis because now you've got stool just chronically draining down there and pain. So that necessarily translates to a certain degree of urgency and tenesmus. So yeah, some patients do well, but you can expect some problems there. My preference is to try to get it to heal rather than to make it bigger, as a personal preference, but it's a very good question, certainly. Let's go back to McGill and see how this was managed, because I know we've got a little bit more time, and let's have Marilise try and finish.
So thank you. Just to give you an idea about what the defect looks like, typically I don't look in at the defect unless I'm having problems to get the anastomosis to heal. So in this case, after 4 weeks and something is still draining, so that's when I would look in. Otherwise, I don't typically look in initially unless I'm very worried, because it wouldn't change my management. And just a point about the transgluteal drains causing fistulas, we looked at our experience when I was in Florida, and in all our experience in Florida, we didn't identify any fistulas after transgluteal drainages of varying lengths of time, so it's very interesting to hear that it's definitely a possible complication of these drains and to be careful. So at 4 weeks, This is how this case was managed in Italy by Dr. Dapri. The patient was brought to the operating room after the fistula was endoscopically managed. Actually, is a very nice video of a transanal endoscopic approach. And what's important is that the patient was brought only after 4 weeks. So typically we wait for these sinuses maybe up to 3 months sometimes to heal, of course not with a draining drain. So this patient was brought to the operating room, and using transanal endoscopy, the wound edges were brought together using figure of 8 stitches. And I have a few other transanal endoscopic videos, so hopefully I'll be able to show them to you. So in general, transanal endoscopy, most of us are quite familiar with it now. There's rigid platforms with proctoscopes that can reach up to the upper rectum, and there's shorter proctoscopes as well as anal access devices that are disposable. And definitely it requires a special equipment and a learning curve. However, transanal endoscopic surgery really allows for excellent exposure and access to these anastomotic problems and controlled placement of sutures. Also, what's interesting is that if you are adept to using these technologies, it's available, and if you encounter an intraoperative complication, to keep it in mind, because you could manage your anastomosis from below. Sometimes it's quite hard to redo or to fix an anastomosis from above. Minimal data on using transanal endoscopy for anastomotic complications. Dr. Dapri has a few case reports with success, and another group published on using transanal endoscopy for all sorts of complications, including anastomotic complications, 5 rectovaginal fistulas following low anterior resections, again with good success. The remainder of the literature is really about managing complications from urologic and gynecologic surgery using transanal endoscopy, and again, it's quite effective. A 79-year-old gentleman, quite obese, difficult lap anterior because of his size. For a rectal sigmoid cancer, you're happy that you got to the end of the case. A double stapled colorectal anastomosis is performed. However, when you test the anastomosis with flexible endoscopy, your air leak test is positive, and endoscopically you think you notice a defect in the posterior anastomosis, and that's where the bubbles seem to be coming from.
Okay, so let's look somewhere we haven't, maybe the Minnesota Institute of Minimally Invasive Surgery, and see how you'd handle posteriorly based, very distal, intraoperative anastomotic leak. We got Minnesota Institute Minimally Invasive Surgery, please, and see. So you've got this defect down low in a morbidly obese gentleman. How would you manage it?
It's a difficult problem. If it's posterior, it's obviously difficult to get to for suturing, but that would be the first attempt laparoscopically to try to oversew that area. Fibrin glue is used here as well, but it might be if it can't be reached. I think they would probably just drain it and try to suture it laparoscopically. If we're very low, there'd be an attempt to try to reach that through a transanal approach, and I believe that's the way they'd handle it.
Okay, so transanal approach, and then there's the issue of diversion and drainage as well. Would you divert and or drain as well?
Yeah, of course there'd be a loop ileostomy for diversion, but I think endoscopic approach with clips from below could be utilized as well.
Okay, good. How about Dalhousie University in Nova Scotia, in Halifax, Nova Scotia? Any thoughts on how you might manage this?
Good morning. Jim Elton here. We don't have many of our colorectal colleagues here. I think what's been described is basically what we would do here. I think I really enjoyed the presentation in general. There's kind of one concept that came up, and that's that notion of what's the first thing to do, not in this case, but where you have a kind of contained perforation. And I think the kind of knee-jerk reaction for most of us is to kind of drain it, whether percutaneously, whether that's surgically, laparoscopically, or interventional radiology involved. But I think if you look at the endoluminal approaches to a lot of these contained leaks, it's really important that you kind of involve your therapeutic endoscopist before you do that, because Now you're managing a fistula versus just a collection that maybe you can manage endoscopically, whether that's with sponges, pigtail drainage, or whatever your whatever your options are. But once you've turned it into a fistula, once you get a drain in it, all of a sudden your options are constrained a little bit. So and that's certainly an issue I deal with on a weekly basis in the upper GI tract. That it's something, and again, there's a few more variables that play in the lower GI tract that have been alluded to through the discussion. But I think that message hasn't come out today, which is, talk to your therapeutic endoscopist about your options before you a patient who's stable and you get a contained collection before you put a drain in it, because it does limit you basically.
Okay, good thoughts. If we can go back to McGill, please, and ask Dr. Boutros to finish off this case and then give some conclusions. We have about 6 minutes left.
Okay, great. So we actually had a case like this where we managed it with just normal hemoclips, and the leak passed. This patient's BMI was maybe 45, and so a diverting loop ileostomy was not exciting. The way this was managed in Italy, here's the positive air leak test. You see the bubbling. And Dr. Dapri just set up transanal equipment and put some figure of 8 sutures where he noticed the defect. Again, as was mentioned astutely, is that posteriorly to just place some sutures laparoscopically may not be easy, and you're at the mesorectum, so you might not be actually closing the tissues that you want. You might be just cinching on the mesorectum. So here he's using a PDS suture. You see, because this anastomosis is at the top of the rectum, it could not have been reached transanally without transanal endoscopic equipment. So here he's using a rigid proctoscope to help him reach to the top of the rectum. And he placed one figure of 8 suture, and now he's placing the other suture. And had I had the opportunity to show you the one with the sinus, where it's more chronic, you see that the tissue, in order to just suture it closed, the tissues really have to be supple. And at 4 weeks in the other video, you notice that the tissues were supple. I used to intervene on these sinuses much later, waiting for about 3 months to see if they would heal, and then try to intervene. By then, the tissues are too fibrotic. So this patient healed. I'll skip this case. So to conclude, from a minimally invasive approach, there's a bunch of things that are in our armamentarium. None of them are a panacea. None of them are perfect. For smaller defects, can consider clips. For larger defects, the endosponge, and it was really interesting to hear the makeshift endosponges we're using in North America. For strictures, if they're simple, benign, short, balloon dilatation, or mechanical dilatation with dilators. Stenting for more recalcitrant strictures or for fistulas, but stenting is expensive, requires expertise. We don't quite have the right stents yet to stay in place. They often migrate. And transanal endoscopy is definitely a highly effective tool when managing rectal complications. However, it's limited to the rectum. I really like the point that was brought up earlier. Think of minimally invasive options and speaking to the right people at your institution when you see a contained problem. And of course, patient selection is vital. You need a patient that's stable with a contained problem in order to think about these innovative options and think ahead, plan ahead before taking the first knee-jerk reaction of percutaneous drain. That was a really good point. Match the defect size and the quality of the tissues to the appropriate intervention. And I think what I learned most preparing this talk is that if we want an innovative approach, I think it's important to intervene early before fibrosis sets in. And in summary, the minimally invasive approaches have potential for great success without a radical operation, permanent stoma, or morbidity of the patient, so it's worthwhile keeping in our armamentarium. Thank you.
Okay, before we bid you adieu and thank you